I'm sorry, that's the only Bahasa I speak. I said yesterday to my wife, that I should go and learn Bahasa, because I think I gave already 50, 60, 70 lectures here in Indonesia for the last few years. So I'll let you accommodate a little bit to my voice and to my English. I will not try to speak that quickly, otherwise you say, "Hey Hans, slow down." Yes? Okay. So first, before I do something else, what's this flower? Especially for me. From my country. Is this true? This is the tulip flower. Tulip flowers you have in maybe 50, 60, 100 different colors. And originally, it's not from Belanda, but from Turkey. And it's important 400-500 years ago by the Dutch people coming to the Netherlands, and there it's growing now. In springtime, in April, springtime in the northern regions. So in April for only 2-3 weeks. That Dr. Tegu introduced me. I'm specialist in apheresis and in transfusion medicine already for many years, in giving internationally many lectures on this, especially on apheresis. That's my super specialty. But I turn this around a little bit. What I'm going to talk about today is antigens, antibodies, and the consequences of these in transfusion medicine. So, immunization, what's that? Can you be immunized against the tulips? A lot of people are sneezing, so there must be something happening. And the fact that we are sitting here, as you know, is because of immunization against it. Otherwise, we would have been killed already while our mothers were pregnant from us. But our mothers were not there when they could not have an immunization. But sometimes it's not that good to have an immunization. But when you talk about an alloimmunization, you have also an autoimmunization, which is even more terrible, I think, in some times. You must have an antigen to respond to. And because of this antigen, which is not yours, otherwise it would be an autoimmunization, you have an antibody response. And that's immunization. But can you tell me, what is the antigen? You all are doctors. What's an antigen? Shall I give the answer? It's a substance we don't have for ourselves, or we have it for ourselves, and that can evoke the production of one or more antibodies, immunoglobulins. Immunoglobulin production. So we have an immune response. And talking only about transfusion medicine. Otherwise, I think the immunology colleges or lessons can be given in 3 months or so. So only 1 hour we go and talk a little bit about transfusion medicine, which is our profession. And in transfusion medicine, the antigens we have are on the red blood cells, the different white blood cells, granulocytes, monocytes, lymphocytes, etc., platelets, and of course also, although it's not that known, in the plasma. When we talk more, we have in the red cells, or for example also in the platelets, we have blood types, blood groups, which are of course antigens. Further important are the HLA antigens, human leukocyte antigens, the HPA antigens, human platelet antigens, and HNA, human neutrophil antigens. These are the most important antigens we have in transfusion medicine. And we all have blood groups, blood types, you know that. And when you are a kit A positive, homozygous, and you receive from a kit B donor some blood, you get foreign antigens and you can have an anti-kit B. So antibodies can be formed if you come into contact with antigens which are not yours. That's everything that should be said for transfusion medicine too. And you should know, these immunoglobulins formed by the B cells are strictly specific. An anti-kit B is not reacting to the kit A antigen or a Duffy A antigen. So very specific, like a key in its own keyhole. And it's only that antigen which is taken care of and which is attacked. So when we look at these antigens, we can have made antibodies against these. So an anti-cal, an anti-small c in the red blood cells, for example. But also HLA antibodies, anti-B7, anti-A1, anti-A2, like that. Also HPA antibodies, antibodies directed against platelets, specific platelets, anti-HPA1A or anti-HPA5B, which is possible. Of course, also on the anti-HNAs can be formed, which can be very, very nasty antibodies in the body. And when we have an antigen-antibody response, we will also have an activation of the complement system. And this is damaging our cells. So when we look in the antibodies, in the red blood cells, in the blood types, we have an effect on red blood cells when we have to transfuse them. This is also, but less commonly known, in the anti-HLA. This can really affect red blood cell transfusions. Of course, HLA and HPA can affect the platelet transfusion, and anti-HNA will affect whole blood transfusions, and of course, granulocyte transfusions too, or lymphocyte infusion. So let's go to the effect on the red blood cells. We don't want this antibody-antigen response in the body, because this is giving hemolysis. So we try to avoid this. So we give ABO and rhesus D compatible. Rhesus D is not that important here, because only a very, very small percentage of your population is rhesus D negative. But take care. A lot of people coming in from Belanda, and I know I was involved in a Belanda woman. She was living in Denpasar, and she was having her child born, and she was O rhesus D negative. So we tried to find some blood here in Indonesia And I even called with Dr. Tegu because I know he has a few donors. And so we found a few donors available to give blood during the cesarean, or just prior to the cesarean. This woman had to give birth to her child. We try to avoid immunization against red cell antigens. Otherwise, we get it more difficult when this person needs more blood transfusions, because otherwise you get always hemolysis, and this is not good. And then you have to find, let's say you have a person who has an anti-Duffy A and an anti-Duffy B. Do you have available Duffy A and Duffy B negative donors? So your donor population is very difficult to achieve in these cases. So try to avoid by giving compatible as much as possible, especially in polytransfused, let's say, the thalassemia patient, for instance here. So what about HLA? Did you know that? Did you know that HLA could influence red blood cells, anti-HLA? We don't have all HLA antigens on the red blood cell, especially A28, B7, B8 and B17 are present, so they will have influence. Especially the B7 is very important, because anti-B7s can give very nasty reactions in red blood cells. You don't see that severe hemolysis like you see when you transfuse an O, type O donor, a patient, you transfuse type A blood. You will see a massive hemolysis of your bag, but you don't see that, but only in the B7. So this is very important to realize, that you should try to avoid also giving HLA antibodies to your patients. Very well known, and Dr. Tegu is writing his thesis on this, is the effect of HLA and HBA antigens and antibodies on a platelet transfusion. But also, very important to know is that there are red blood cell antigens on this platelet. So this platelet has the ABO blood type, for example, but also the Lewis, also the I, and also the P1. Why? What? Do you see a connection between these blood groups? Even the first year resident of pathology working in transfusion medicine should know what's the connection in between these blood types. Have you ever heard of the H antigen? Not yet? They don't know the H antigen? It's the basic of the ABO. So you have the four sugars. They form together the H antigen. And the Lewis, the I, the P1 and the ABO are all by adding one or two additional sugars to it. That's the blood group. So the H antigen, including these blood types, are present on the platelet, not the Cal, not the rhesus factor, not the Duffy, not the KIT, but these are present. Further, we see HLA antigens on your platelets and HBA also. You recognize it again? Yes? H, the B with the additional here, the A with the additional, and the Lewis. Yes? So we have an ABO antigen on the platelets. So we should take care of the anti-A and the anti-B in your patient. It's not good to transfuse A platelets, type A platelets, to the type O patient. That's not good. Why? What is it? Because, oh, by the way, you have also an anti-A and anti-B in your product. And there are a few cases in the literature causing a massive hemolysis with the death of the patient when there was a donor with a very high anti-A, an O donor, type O donor with a very high anti-A, and this product was given to a patient, blood group A, and this patient died because of a massive hemolysis. It was a titer of 1 to 1,000 or so. So it's a very high titer. It's a possibility. So the major ABO incompatible, so giving the A type to a patient with an anti-A gives a lower CCI, a lower increment corrected for the weight and the size of your patient. It's one of my other presentations. And this starts very early, already after 10 to 30 minutes starting the transfusion. So you have a decrease of 1/3. You need to transfuse much more platelets with the same effect. So, and the CCI is 40% less good. But also, why are you giving this platelet? Because you want to help your patient in the aggregation when it's needed. That's the reason you give your patient your platelets. But it's inhibited in some cases more. So, lower effect of ABO, major incompatible. The minor, except for the cases I told you with the death because of massive hemolysis, can give some reactions in the Coombs test, the direct Coombs test. This will give you again problems with additional work when you need also to give red cell transfusions, because your cross matches can give problems and your blood type can give problems. So you should take care of that. Then go to HLA and HPA. You know, the HLA system is a very complex system. When I remember well, it's located on chromosome 6. You have a DP, DQ, DR, and a B, and a C, and an A antigen on it. For the platelets, only the A, B, and C are important. A lot of subtypes. You can't count all because hundreds of them, thousands of them. You get one of your father, one of your mother, one of your father, one of your mother, in the A's and the B's and the C's and the D's also. Very complex. And what's it doing? Make it a little bit easier. It's giving a kind of barcode on every cell in the body for your own recognition. Your T cell is scanning it. Hey, mine, mine, mine. Oh, foreigner. We should detect this one and make antibodies. So, HLA antigens on platelets. We have only a class 1 on it. So, A and B and the C, but the C we don't have anything to do with that. We don't deal with that. When you have antibodies, what would this do? HLA antibodies in your patient. What would it do? Would it help? Would it be of help? Would you have a better or a worse increment? What's your experience in this? Your experienced residents, what's your experience in this? Even in Bahasa you can answer. How do you get them? The lady and the Adonis decide to have a marriage, decide to have a child. The child gets, this is a homozygous A2, homozygous A1, so the child will be in A1, A2. And we know now that almost during every pregnancy, blood will flow from child to mother and give HLA antibodies. How often? One of my students, one of my co-workers, published in 2010 in 1100 never transfused female blood donors of my cohort, that you see an incidence or a prevalence of almost 40% in female donors, so also in female patients, almost 40% of antibodies against HLA, one or more specific. Transfusion, never transfused males, so about 6%. We don't know whether it is. Is this clinical significant or clinical relevant? We don't know. Almost 6% was it. And 10%, so 4% more. So we learned from this that increasing with the number of pregnancies, you have an enormous increase of the frequency of prevalence of HLA antibodies in a body. The second thing we can learn is that transfusion is increasing the frequency of HLA antibodies. And you should know, it should be aware that this is leuko-reduced blood already. Or it is blood coming from buffy coat depleted red blood cells. It's not whole blood. So it's a completely different way. What's leukoreduction? Leukoreduction, it will come back later in my presentation, is less than 1 million cells, white cells. In a buffy coat depleted product, you have about 100 million, 1 times 10 to the 8th per unit. And in the PFP method you're using, you have about 10 times more. And of course, in whole blood, you have what we have. So, continuing with this, you see this is rather flat, that it's going down a little bit. So, even when the pregnancy was over 30 years ago, your HLA antibodies will remain there. So, young people, in a normal way, rather young people will have their child. And then they get transfused because they get leukemia, and they were treated for the leukemia or the AML. And they need platelet transfusions. So even after 30, 40 years, these HLA antibodies will have influence on the transfusion, because the patient will be refractory. Not all is due to HLA-1, but also HLA-2 or any HLA or HNA or any leukocyte. So more than 50%, and this is also from Rutger Middelburg. So you see a lot of influence of especially pregnancies. Is there any difference between an abortion or a complete pregnancy? Yes, there is. Abortion only or live birth, more than abortion and live birth. So we had a lot of information from these donors. Is this unique? This is in Africa, in Nigeria, to be honest, from this publication. And he saw the same, 22% HLA-1, anti-HLA-1. And what did Rutger see? It's the same, anti-HLA-1, about 20%. So, it's the same in more continents. Should it be different here in Indonesia? I don't think so. This is also the same figures. So almost 1 in 2 multiparous women have HLA or HNA antibodies. But, this seems rather high. When we have an AML patient, not 1 in 2 female patients are refractory. There could be some reasons for that. It could be specifically, let's say, an anti-A28. And you have donors who don't have the antigen A28. So this could be also. Where is HPA coming from? As you know, this is the function which is needed to function for the platelet, for the hemostasis. You have the endothelial cells, you have the von Willebrand factor needed, you have the platelets needed, and you have the fibrinogen needed. So, first of all, you have the adhesion because of the damaging or the release of von Willebrand factor. This von Willebrand factor will go as a very long protein along from the endothelial cells into the bloodstream and will stick your platelets to. But then you have also an activation of the clotting system, and fibrinogen is produced, and this is the aggregation of the platelet which is needed in total. And for this you have all these kind of receptors needed. And when we look more closer to them, you will see this is the receptor which is needed, which is the 2A, 1A, GP1A, 2A receptor, which is needed for the collagen, so the binding of the von Willebrand factor, that specific parts are unique for a platelet. And these are the HPA. HPA5, here you see. This is the 2B3A receptor, which is needed for the fibrinogen. This is the adhesion place for the fibrinogen. And you see also 6, 7, 1 here, etc. So in short, all kind of different receptors are placed on your platelet, needed for the function, the correct function of your platelet, and specific parts will form. So, looking back at this African publication, you have, again, anti-2B3A 10%. 1A So this is the receptor for the fibrinogen. This is the receptor for the thrombin factor. And this is alloantibodies. We should take care. Ever heard of Bernard Soulier and the Glanzmann disease, which are diseases of the 2B3A. So try to avoid giving them antibodies. So antibodies against 2B3A is specifically the HPA1, anti-HPA1, HPA3, HPA5, HPA2, and these two, 1 and 5, are not good. They can cause severe reactions. What has these things to do, anti-HLA, anti-HPA, with a normal platelet transfusion? So what you do, patient is starting with the chemotherapy. You see a very quick decrease of your number of platelets. What you do then, when it's below the 10, you give a transfusion and you wait until it's below 10, you give a transfusion, and after about 10 days, after normal start, your patient is making his own platelets again, and okay, you wait until the next chemotherapy. This is normal. But when you check this more and more, you will see an effect of your platelet transfusion over day. 1 hour, 1 day. So you will have a decrease. Why is this decrease? Can anybody tell me why there is a decrease of your platelet count? What's your normal function of a platelet? It's the integrity of the endothelial cells. And your body needs about 10,000 platelets, 10 to 15,000 platelets per day to keep your body or your endothelial cells in your vascular system in a good condition. Because what you do is you hurt yourself, or you step outside of your bed, you walk to the toilet, and this is damaging some endothelial cells. And you need them. So you need your endothelial cells, and so you need per day some platelets. Furthermore, of course, you don't produce your own platelets, so you will have a decrease because a lack of production. 1 hour, 24 hours, or 1 to 6 hours, 24 to 48 hours. That's normal reaction. But what if there is no reaction at all? So you have a flat line despite all transfusions. This can be caused by you using them because of a bleeding or a clotting or a big spleen, some medication, antifungus therapy, fever, infection, sepsis, but also antibodies. So, and no reaction on platelet transfusions is what we call your refractory for platelets. No effect. About 80% of these refractoriness in patients is caused by a non-immune refractoriness. Bleedings, your big spleen, or some medication, or the neutropenic fever. But the remainder is immune refractoriness, and we can do something against that. to check whether you have what in your patient. What's the therapy in your platelets to do this? To cover your patient with sufficient platelets. What's the therapy? Should you give more platelets per day, per dose? Any suggestions? Or should you give more frequently? My advice is always not to double the dose, but to decrease the time in between. So go to a daily transfusion of sufficient platelets, or even go to 3 times a day, every 8 hours. Why 8 hours? You see, there is a non-immune refractoriness after you have sufficient platelets after 1 to 6 hours, but after 24 to 48 hours there is not sufficient. And let's say this is the 10 here. You need to give not a double dose, because these double dose is exactly taken away as quickly as the remainder from the body, but give more frequently. So every 8 to 12 hours a dose. You can learn this from this graph. This is also a possibility. So when you see this graph, this is caused by immunoglobulins. Even after 1 hour, there's nothing left. So you need to do something else in this case, because doubling the dose will give only a higher peak and not more than that. And doing this after 6 hours, giving some peaks, additional peaks, but no increase, and below 10, you have a chance of brain bleedings and bladder bleedings. So you need to do something. Something else is, so you see, I know your residents. So what's typical on this? Do I need to receive the same amount of platelets as you do? I'm looking for, as you do. Or even as you do. No, of course not. So we should count with what is the dose. That's depending on you. That's not on me. But we should have a corrected count increment. So you can say, I have a platelet count of 8,000 in my patient. I give my product, and after my transfusion in 1 hour or 24 hours it's 30. I have a count increment. But when you give me a transfusion, or you give you a transfusion of the same amount, there will be something different. So this is the corrected count increment. And this is based on this a definition. You have a post count minus a pre count. Let's say 50 minus 10, 10 times to the 9th, we can make 10 times to the 3rd of it. The body surface, what's my body surface area? About 2.1, 2.2. But what is normal here in Indonesia? Yes, 1.6, 1.7, depending on your male or female. And the transfused number of platelets? And when you do consequently this after 1 hour and after 24 hours, you can say, which is normal, that it should be above 7.5 to be normal, or after 24 hours about 2.5. That's the CCI, the corrected count increment. And when you have 1 and 24 hours. So this is completely normal. Normal situation. So in our guidelines in the Netherlands in transfusion medicine, every clinic has the needs to give a count after 24 hours. That's needed in every patient needing platelets. Otherwise, we can't help. That's guideline. When it's lower than 7.5, you can have these kind of situations. After 1 hour, it's a must, around to 10 or so in this kind of situations. But here you see sometimes a CCI of 2 or 3 after 1 hour. So this is what we call the patient is refractory for transfusion. And what we should do in that is given here in tissue antigens in 2012. You have platelet refractoriness. About 80% is caused by sepsis, and we have immune factors in about 20%. The majority is HLA, 10 to 20% HPA, about 5% is a combination of HLA and HPA, and remainder, we don't know. Autoimmune. Sometimes we don't find anything, aspecific antibodies, but causing something. We can't do anything with that. Give immunoglobulins. That's the only thing what we can do. But keep this in mind. When you walking around on Malioboro and you hear this, is it a zebra or is it a horse? On Malioboro, this will be a horse. So count for a horse, count for HLA, and don't go to HPA unless you don't have any reactions. So what we do is, even when we don't know in our situation, we have a patient who is refractory for platelets, we give HLA type platelets, HLA compatible platelets. When that's not working, we give HPA type platelets. And when that's not working, we give a combination. But there is an anti-HLA here in Indonesia. What then? Or you have a refractoriness and you don't know. You have a source in the Netherlands of about 35.000 HLA typed donors. So I have a huge database available to find HLA compatible donors. And you should do an apheresis procedure. An apheresis derived platelet component is a blood component. There's a discussion going on in Indonesia, I know, between the Ministry of Health, insurance companies and blood transfusion services, but it is a blood component. HLA compatible donors. Do you have HLA typed donors? Yes, of course you have them. Because you have a family donor. you have family donors. And what is the source of your HLA? What's the source of your HLA, the HLA type you have? That's your father and your mother. So, who is the better donor than your father and your mother? And I don't like mothers in this, because 40% of them has antibodies against me. I don't like that. So I prefer, in fact, the father, brothers and sisters, when they are from the same father and mother, of course. Adult children, and of course not the partner, because the partner is the person who gave you the antibodies through the child when you're a female. So, what's easier for you? To take the family donor, the brother or the sister, ask them not to give a whole blood donation, but give an apheresis donation. What you can always do is a platelet cross-match. It's very easy, mixing them together in a MyPa or in a, and Dr. Umi can learn that very easy, because we invite her to Amsterdam then to learn that. So that's very easy in doing a MyPa or an ELISA. It's a stupid ELISA, so you can do it very easy. And then find your matchable donor without doing HLA typing, etc., etc. So this is very easy to remember. But. Together with your component, you give also T cells, because it's not leukoreduced, and even in leukoreduced cellular products, you have T cells of a high quality functioning, and they can give. What can they give? Transfusion-associated graft versus host disease. Who of you can treat transfusion-associated graft versus host disease? Who of you? Anybody? Because you received the Nobel Prize, I think, when you can do this. Nobody can. This is usually deadly when you achieve that. So take care of that. And the radiotherapy unit of the hospital can help you in this. It's not needed to have a blood irradiator. The unit of radiotherapy, even also available in the Sagitto hospital here, can help you with this. And of course, always check the CCI. So you know already the answer to the question, is CCI, as one of my presentations on Wednesday, I believe, is the CCI needed for a platelet transfusion? The answer will be yes, done. But 80–90% is HLA, but your HLA is not working. Your HLA donor is not working. What then? You take, of course, HPA type donors. How much do you have? None. Again, who gave you the HPA? Your father, your mother. So again, use the family donor. Platelet cross-matching you can do. Normally, it's not needed in HPA-typed donors, HPA-compatible donors, to irradiate the product, because they are not HLA matched. But in case of family donor, every component from a family donor should be irradiated. and again check the increment. What's this? What do you see? What do you see here? What's this? It's a little bit difficult to see on the screen, but these are all petechiae, all small skin bleedings. This child is only an hour ago was it born. What's happening? Also caused by HPA antibodies. When you do a CT scan, you can see this. You can't miss it on your CT, I think. I hope. Huge bleeding, intracerebral. ITP, neonatal alloimmune thrombocytopenia. It's rare, I know. 1 in 1,200 to 5,000 gravities, and 85% is caused by an anti-HPA1A. 30% is caused by a 5B. Sometimes a combination. This can cause thrombocytopenia for 3-4 months. So sometimes you need transfusions. The best donor for you in this case is the mother. But not a whole blood donation of this mother. She suffered enough. She gave birth an hour ago. So she needs, even 1 hour after the delivery, she needs to go to the apheresis department to give her platelets for this child, the survival of this child. Can be very severe, below 10 in this child. So, how is it caused? Usually, we have this beautiful lady again, and this Adonis. They give to this child 1 AB. Blood goes into the mother, and the IgG is actively transported through the placenta to the child, giving already in utero a very low platelet count. So your child will be born with 10 platelets, 10,000 platelets. So I really do know that there is a difference between Caucasians. This is not available from the Indonesian population. But when I look at China, Taiwan, and Vietnam, you see 89 to 99% is HPA1. So the lady, there is only 1% chance that the female person is a 1BB, has a 1BB. And there is a big chance that her husband is 1A. So there is also in Indonesia a possibility to get this. Usually you don't measure your platelet count in your newborns, but sometimes it's a terrible shock sometimes when you measure to the lab a whole blood or CBC count on your just born. So there is a possibility. Oh, sorry. Then go to the HNA, the neutrophil antigens. There is an effect on whole blood because when you give whole blood, your granulocytes will disintegrate. Also, these are in the receptors. HNA are in the receptors of this. So it can cause, of course, in whole blood, it can cause a granulocyte destruction. And what will happen when you have a granulocyte destruction? You will have a non-hemolytic fevers, transfusion reactions. So that's the reason you should not give whole blood anymore. But also we are very afraid of a trali. in the patient, of course. HNA antibodies and HLA antibodies in the donor. But how often do you see febrile transfusion reactions? How many transfusions are you giving? 5,000 here, 10,000 a year? In this hospital? 13,000. And how many febrile transfusion reactions do you see? 4%. Yeah. 4% is reported by the nurses on the ward. 1 in 100 transfusions is very useful. It's very normal that you have in 1 in 100 blood components you will see febrile transfusion reactions. It's very normal. So 4% can be very normal too. Yeah. So febrile non-hemolytic transfusion reaction is giving fever and no hemolysis directly. It's usually anti-HNA or anti-HLA. And this is prevented by leukoreduction. So, HLA or HNA antibodies can give TRALI, transfusion-related lung injury. It's a non-cardiogenic pulmonary edema. Your granulocytes will be activated, or the granulocytes of the patient will be activated, and the endothelial in the lungs is dissolving completely. The endothelial, vascular endothelial. So, your patient will drown in his own plasma. All plasma is going to the alveoli. Within 6 hours, and it's rather frequently present, and you will have, this is caused by, it's a combination of the donor with this patient. You will have white lungs. This is not an overload, a fluid overload, a TACO. This is TRALI. You see the difference in the pulms. This is prior to the transfusion. This is within 1 hour after transfusion. You can. What should be happening when you give Lasix, furosemide? What would happen? Is it releasing the dyspnoa of this patient? No, it's worsening. It's worsening. So Lasix is not helping. It's worsening. So take care of that. Think of it. Remember it. A lot of people will die because of it. Because when somebody is getting dyspnoa after transfusion, the first thing what you give as a doctor is Lasix, because you think of it of an overload. When it's not helping, transport this patient to the ICU, to the IC, intensive care unit, because you need to give a lot of oxygen and sometimes you need to help this patient with breathing. Think of it. HNA antibodies, HLA antibodies. So, in fact, my presentation was Allooimmunization against neutrophils and platelets and the clinical significance. But, in fact, HLA, HNA, and HPA, the clinical significance. So we discussed what is an antigen, which antibodies can be caused in transfusion medicine, or do cause antibodies, and the consequences in transfusion medicine. So thank you so much again for inviting me to give this lecture. I hope you have some thoughts now and some questions, because I'm happy to answer them.